In contrast, here's a patient who had some abdominal pain post a radiologically inserted gastrostomy, and we can see here that there's the classic bilateral clustered bronchi space-losing process, very characteristic of atelectasis. So if we call this patient bibasal consolidation, we're doing them a disservice, and the patient might be started on antibiotic treatment. We should call this bibasal atelectasis, and the patient should be treated with, if anything, chest physiotherapy, perhaps sitting them up if they can, and pain relief in order to improve their aeration, oxygen, and then if we did a scan which identified a specific mucus plug, unlikely in this case because it's a bilateral process, but if there's one specific area, bronchoscopy might be appropriate and can be life-saving, particularly in patients with asthma or those in the intensive care unit. Now, it's certainly true that consolidation can be associated with adjacent pleural effusions, and we have to aspirate those effusions, aspirate parapneumonic effusions, because they may contain infection. We need to drain those, we need to know about them to prevent the patient getting an empyema. If we treat them early, we can avoid decortication. But a very significant amount of the time, this pattern here is produced by atelectasis from the pleural effusion, which compresses the adjacent lung and collapses it down. This is an almost universal finding in large pleural effusions, but unfortunately people continue to call this consolidation, and the fact is that it isn't. So we have to judge the size of the effusion and also the same collapse consolidation signs when we're assessing this, but we should really be alert to the fact that large effusions will inevitably cause atelectasis in the adjacent lung tissue. Here's another example. This patient had a hemoglobin drop, day 4 post-laparotomy, post-laparoscopic hemicolectomy. We can see the pleural effusions in this case aren't very big here, but we have extensive atelectasis in the right lower lobe, and there's a bit of atelectasis here in the left lower lobe. It's a bit unlikely that this patient has bilateral lower lobe pneumonia, so let's not diagnose them with that. Here's another patient who had surgical emphysema, no cause identified, atelectasis here, bibasal and large pleural effusions. Here's a patient post-laparotomy for trauma. Again, we've got these clustered air bronchograms, the characteristic smoothly marginated pattern of a collapsed portion of lung tissue with an associated pleural effusion. It's hard to say whether the pleural effusion is the cause or just happens to be there when it's associated with collapse, but it's still important that we don't rush to call this consolidation. Because if you say there's consolidation and a pleural effusion, you're immediately suggesting that you are inferring, should I say, that the patient may have pneumonia with a parapneumonic effusion, which we need to at least aspirate to make sure it's not infected. Here's a patient who's just had a gastrectomy, and we've got some oral contrast in their gastric pull-up, which is very important to give these patients positive oral contrast when you scan them to look for a leak. And here we've got atelectasis, clustered air bronchograms around the pleural fluid. More atelectasis over here. So it's unlikely this patient again would have bilateral symmetrical pneumonia, consolidation causing pneumonia, should I say. Another example, patient with shortness of breath, query pulmonary emboli, again a bilateral symmetrical process with pleural effusions. So here's another patient, and this person was found lying on the floor for 2 days before they were taken to hospital. And I just wanted to show you this case because it demonstrates how things are not always straightforward. Here you can see that there's extensive opacification in both lower lobes. This patient didn't have any symptoms of chest infection and went home promptly after they had received some care in the hospital. But I did tell you that you can look on the coronal and sagittal reconstructions and demonstrate how there is reduced volume in collapse. But if you look at this patient here, you can see that there's still extensive airspace opacification, but very few air bronchograms present here. Now, I'm not quite sure what the explanation is for this. I don't think this was actually consolidation in the true sense, because the patient was promptly discharged, and if this was infection, it would have been very extensive. It would be unusual to have such severe bilateral pneumonia. I think this is a form of atelectasis, but I'm not quite sure of the explanation for this appearance, and I think perhaps these findings have to be judged in the clinical context. Here's a patient who fell off their bike onto the ice, and they did sustain several rib fractures and clavicular fractures. And the first scan here, which was performed on their admission, doesn't actually show any significant abnormality at the lung bed. And then the repeat scan performed on the 23rd of January shows us extensive airspace opacification in the lower lobes with the clustered air bronchograms, very much the appearances of bilateral basal atelectasis. So not consolidation. Again, the patient was promptly discharged in this case. Here's another patient who came in with abdominal pain and to deal with their abdominal issues, and here's a repeat scan on the 22nd of January. Again, this time we have bibasal atelectasis with pleural effusions. There was no specific reason found for these. It's not as though the patient had extensive ascites in the abdomen. The rest of the images, this is just a process which patients tend to get when they're lying down all the time in hospital. I can't say that it's usually as extreme as this just from the act of being in hospital, but I don't think I would describe this as consolidation. I would describe this as bibasal atelectasis. Here's a chest x-ray just for a change. We can just see on this patient here that there is opacification in the right upper lobe extending to the oblique fissure here. On the CT scan we can see that there's diffuse increase in density. This is very severe interstitial change, probably just about to develop some air bronchograms here and here, and so I would say this is what is almost consolidation, not quite. And we were talking before about atelectasis, the junction between interstitial change and developing proper atelectasis. I think this is the case in a pattern we sometimes see in severe pneumonia. The interstitial change forms and it then becomes more obvious and develops into very dense white airspace opacification or consolidation. What would we call this? This patient hasn't lost any volume in this area. There are probably a couple of air bronchograms. It could certainly be aspiration because the patient has vomiting here, but I would like to say this is probably a small area of consolidation in the right lower lobe. Here's that dependent change type appearance. Maybe it's a little bit of atelectasis here. Quite difficult to say, but most likely not of significance. Here's an example where the patient has a very smoothly demarcated wedge-shaped density in both lower lobes. This was a patient with acute myeloid leukemia, query pulmonary embolism, and this is the appearance of partial segmental atelectasis in the lower lobes, not consolidation. And here's that same picture again on mediastinal windows. And a little bit further down. This is a pattern which is quite commonly seen. You've probably noticed it before. This curling pattern of linear density, which is seen very close to osteophytes. You can see it here in bone windows. I'm not sure what the explanation is, but it's perfectly normal. You can comment on it if you wish, but don't make anything of it. So just going to look at a couple of reports now. and you can see how the reporting is very significant. Sometimes this patient has some densities in the lower lobes here, rather linear I would say. And here's the report, which says bilateral patchy consolidative and atelectatic changes, which in the context of trauma may represent contusional change. So I don't think this is very helpful really. It's lumping contusion, consolidation, atelectasis all together. Contusion, of course, one would expect to be a cause of consolidation, but everything really is just put together in and all covered, and the radiologist hasn't really attempted to hone in on a diagnosis for the appearance in this case. And I think that this is probably, I think this is quite clearly best described as atelectatic changes at the lung basis. Here's a patient with post-cholecystectomy pain, and we can see here that there's a pacification in, and here's the report that the person gave. The clinical information was open cholecystectomy, tachycardic, high inflammatory markers. So there was certainly a query about infection in this patient, and the first line of the report says bibasal consolidation with basal pleural effusions. So a person reading that report might think that the radiologist was implying that the patient had pneumonia at both lung bases, and I don't think that's the case here. So that's the end of part 3. If you have enthusiasm for some more cases, we have more available in part 4. Thank you.